For this session of the Covering Rare Diseases Journalism Fellowship Program, we're going to be discussing an issue that several of our earlier speakers have referred to quite often, and that is the role of rapid newborn genetic screening. It's essential in detecting rare disease early, as many diagnoses are achieved when people are still very young. We're joined by Charlotte. She's the Vice President for Research and Clinical Management at Rady Children's Institute for Genomic Medicine. Dr. Hobbs, thank you so much for joining us today.
Thank you, Rachel. It's really a delight to be here, and I thank you and the National Press Foundation for allowing us this opportunity. Thank you.
When I recalled my first conversation with you, I remember you talking about the fact that when you started out as a young pediatrician years ago, you could have never foreseen the ability to diagnose and treat babies in the way that's occurring right now. So once again, I'll ask you the same question I've asked some of our other speakers. Do you feel that we're at an inflection point when it comes to the ability to detect and treat rare disease, particularly in infants?
I really do, Rachel. I think that we are at a point where the science and the evidence and also the technology and the landscape in terms of reimbursement, cost, and have all come together to bring us to that inflection point. And so I do think we're at a very different stage than we have experienced in the last 2.5, 3 decades.
We're privileged to have you join us because we know that the research done at Rady's is some of the leading research globally in early newborn detection. So I'd like to ask you to go to your presentation, but you'll also be telling us about a new initiative called Beginnings. So please take it away.
Okay, thank you so much. So I'm going to begin by telling a story of sort of my progress to this point. I went to McGill University where I did a PhD, completed a PhD in genetic epidemiology. At the time when I completed it, the Human Genome Project was just at the very beginning stages. And I also then went to medical school at McMaster University. And both of these universities really emphasized to physicians the need to practice medicine that was based on evidence from scientific literature and also from expert physicians who had been in the field and that we could learn from many of them over the years. So I felt like I had a really good basis from which to build a knowledge that was informed by the literature and informed by advances in science. That said, then I moved to, I fell in love with an American, and then I moved to Arkansas Children's Hospital and to the University of Arkansas for Medical Sciences, where I completed my residency in pediatrics. And it was in my medical school training, as well as when I began to be a physician as an intern and a resident, where my passion for working with the youngest of populations began. I became a neonatal hospitalist and was a neonatal hospitalist for over 2 decades, where at the University Hospital was where we would have deliveries of women that would come from all over Arkansas. We were the only tertiary level 4 OB unit in Arkansas. Similarly, we had the only level 4 nursery neonatal intensive care unit at Arkansas Children's Hospital, where similarly, we were able to provide care to the sickest of babies in the NICU at both settings. And I worked in both of those settings over the years and was able to see the real growth in newborn medicine and in screening in particular and relevant to today. So when I first started as an attending, we would be knowing that the state, and we were similar to many of the 50 states in the US, we knew at that point that we were screening babies, meaning babies who were healthy, all babies who were born in a hospital setting, and even those who would have a home birth and then their parents would have them screened later. We would screen all babies for 4 conditions. As time progressed, then new technology in the form of mass spectrometry was brought into screening and into the public health program. And we were able to screen for not just 4, but we started screening for many more. In California now, we screen using mass spectrometry for about 80 conditions. When a new technology came to test babies' hearing, autoacoustic evoked emissions, we were then able to screen babies for hearing disorders early on, before they went home after their initial hospitalization when they were born. Those babies would be screened for hearing disorders, and then eventually states also mandated for babies to be screened for critical congenital heart defects. And so that was really the progress that I have seen in the last 2 decades. So going from 4 to now about 84, 85, and it does depend very much on the state. And the screening would advance and the number of conditions would advance as the technology advanced. At the same time, we were in 2003, there was a celebration of the completion of the Human Genome Project. And this was really an amazing feat, both for private industry, but also for public efforts, many of which were led by the NIH, the individual who was the NIH director just till recently, and that is Dr. Francis Collins. And it was his vision that allowed us to really complete the Human Genome Project. And I remember at the time when that was completed, I had just started to be funded by the National Institutes of Health for the science work that I was doing in my lab, where we would be looking at genetic determinants of structural defects, including congenital heart defects. And when the Human Genome Project was completed, there was a real buzz and excitement and enthusiasm about how we could take these new opportunities to apply the completion of the Human Genome Project to the practice of medicine. And of course, we've seen that over the years as there have been different initiatives, including the Moonshot, including precision medicine, that are fundamentally based on being able to think about the individual at the very molecular level, as you will have with your DNA, and be able to understand what is it about that individual's DNA that requires us to provide them with very precise treatments and interventions. Just to tell you a little bit about Rady Children's Institute for Genomic Medicine, where I've been now for almost 4 years. It is a nonprofit research organization. It is associated with Rady Children's Hospital in San Diego, which is the largest children's hospital in California, and the 5th to 6th largest hospital, children's hospital in the US. We at the Institute, under the direction of Dr. Stephen Kingsmore, who unfortunately can't be with us today because I believe he is just descending today Mount Kilimanjaro. So he made it to the summit. We're all relieved and taking a real sigh of relief that he's healthy, made it there, and that now he's coming down from the mountain. So there was, Stephen had an amazing vision about being able to apply whole genome sequencing to the care of critically ill infants and children in intensive care settings. And his work has really led to both national and international initiatives in our understanding of applying precision medicine to the most critically ill children. We also were able to show that not only was the diagnosis effective, but also the diagnosis for children, and about 35% of children, when they have rapid whole genome sequencing and they are critically ill, will have an underlying monogenic disorder that will provide clinical utility. And that when we think about clinical utility, we're thinking about the physician at the bedside who's given a report that the patient that they are caring for has an underlying molecular diagnosis. That physician then can say, based on this diagnosis, do I want to change the management of this patient? That is, does this molecular diagnosis trigger me to introduce new medications, consider new surgical procedures, move forward with new interventions with respect to diet or therapies? And so we have been able to show in multiple studies that the cost effectiveness of rapid whole genome sequencing for critically ill children is very clearly demonstrated. So here we're just giving you a little bit about the number of children that we care for, the number of hospital partner sites that we have. I do know that from my partners here at the Institute that this number is now 83. You see that there are the diagnostic rate we usually say between 33 to 40%, and then changes in medical care as well. We have partnered, as I said, with about 83 different hospitals. We have worked to bring the rapid whole genome sequencing to the attention of payers, especially, for example, Project Baby Bear was a study that was conducted in California in 5 hospitals where Medi-Cal, that is the California Medicaid, was able to provide for babies to be sequenced, and it was called Project Baby Bear. Since then, there is an ongoing study in Michigan similar to Project Baby Bear called Project Baby Deer, one that was completed in Florida, also demonstrating cost effectiveness, called Project Baby Manatee. We've also begun to work with payers who are now reimbursing for, in about 6 states, reimbursing for the use of rapid whole genome sequencing among the population of very ill infants and children. The evidence is clear that across 31 clinical studies that children who are critically ill will receive a genetic diagnosis, and you'll see changes in outcome as well. So the burden of genetic disease, though, is still unclear. And one study that we have done that has been funded by the NIH has been done in collaboration with Dr. Stephen Kingsmore, who is a principal investigator, and he is joined by Dr. Christina Chambers, who is an epidemiologist and faculty member and vice chair of pediatrics at the University of California, San Diego. In this study, their hypothesis was that children who have died within their first year of life, that is, infants who have died in their first year of life, will have underlying genetic disorders that is over and above what we would expect in the general population. And so to be able to do this study, we have worked with the California Department of Health to be able to use dried blood spots that were collected during newborn screening and work with these dried blood spots to extract DNA and then sequence the DNA to identify underlying monogenic disorders. As you can see on this slide, 31% have been diagnosed with a genetic diagnosis that was not diagnosed prior to the baby's death, and that of these 31% of babies that had a diagnosis, we anticipate or expect that 57% of these conditions would have had an effective treatment. And so you can see on the little picture of the baby's foot that to collect the blood for these dried blood spots is just simply usually within 24 to 48 hours of life. After the baby is born, it's a little needle stick. We call it a heel stick because we stick the baby's heel, and then we're able to take blood. We put the blood on a card. The blood dries and it becomes a dried blood spot. So that is the technique that is used for screening. I would say, having worked again as a neonatal hospitalist, that working as a neonatal hospitalist, that most parents are not necessarily aware of the fact that the child has had a screening test, not because they're not told by the nurse, but you have a baby, the baby's say 24 hours old. They have to be 24 hours old for us to proceed with the screening test. We come into the room of the where mom is, and she may have other children there. She may have her partner there. She may be just finished breastfeeding. The nurse says, I'm going to take your baby for the screening test now, and we'll bring the baby back in 10 or 15 minutes. And that for most newborn parents, that is all that they will know. And they won't know more about the baby's screening because the diseases that we're looking for are rare, and most babies won't have these diseases. So that is why screening may not be part of the general conversation when we ask parents in focus groups, what do you remember about screening? Many of them are not able to remember a lot about it. They are more likely to remember the fact that their baby had a hearing test, which is also part of screening. Now, it was interesting because Rachel asked, are we at an inflection point? And I said, yes, I think that we definitely are. So you can see on this slide, and I was looking at it and thinking, really, we need to, if we look at just the number of genetic diseases, we need to really be, recent evidence, more recent studies have shown us that it's probably more like 10,000 genetic diseases, known genetic diseases. When we look at the time to diagnosis by rapid whole genome sequencing, we can see that it has really gone down since the whole genome sequence of one individual, although it wasn't rapid, it took 13 years. And now we are at a time where it can be about 7 hours to a diagnosis. In our lab in San Diego, it is about 13 and a half hours that we've been able to return a diagnosis to the bedside of a baby who is in the neonatal intensive care unit. And then the cost of rapid whole genome sequencing is truly coming down from what it was when the Human Genome Project was finished 20 years later. Illumina has just announced that they believe that they will have a genome that will be in the low hundreds of dollars, which is just amazing that we're moving in that direction, and fantastic, so that many more babies, we hope, will be screened for newborn diseases. So we are trying to think about, when we were discussing, what's the next direction? It seemed like the next direction was very much the trajectory of screening asymptomatic babies. So before babies are admitted to the neonatal intensive care units or the pediatric intensive care unit or cardiovascular intensive care unit, before they are admitted to any of those units, would it not be better to screen those babies as part of newborn, as a screen that is done similarly to the screen that is currently done for other diseases? We mentioned about 85 of those diseases. So is it possible to identify molecular monogenic disorders among asymptomatic babies who don't yet have symptoms? So we've been really working on that idea over the last 24 months. And we haven't begun our research, our prospective research studies yet. We have published about 3 studies in the literature to show the prototype and the success of the prototype to be able to return sensitive and specific screens of identifying variants among a population, a general population. So we also really want to think about how we can be part of a global initiative that is talking about using newborn genomic sequencing. So we were fortunate enough to be invited to and attend a conference that's called the International Collaboration on Newborn Screening that was hosted by Robert Green and a Harvard program. It just took place at the beginning of October, and there were at least 7 or 8 different initiatives globally where individuals are beginning to conduct studies, research studies on the effectiveness of using whole genome sequencing for newborn screening. So we feel like there really is an amazing initiative now moving forward. And we think that the system to be moving forward is we need to provide some components that are really important in a learning healthcare delivery system. So we need to educate and engage both parents, because in this case, we will have to have consent because it is a research study. That is Beginnings is a research study. So Beginnings is the program, and then within the program, within Beginnings, we will have different research studies, and I'll be talking about those as we move forward today. So education and engagement of both parents and providers and researchers, a testing, and then confirmation, because the whole genome sequencing that we will do in our lab will be result in a clinical report, but it is a clinical report of a screening test. And any screening test will require further confirmation that in fact that there is a true positive or a true negative. There will be thoughts about how we can take the information that we have from the newborn genomic sequencing and translate that into the provision of effective treatments. And then once that is done and we've provided care for the individual child, there will be a real hope that if we are collaborative and collegial across not just the US, but globally, that we'll begin to learn more and more about these rare diseases that present in childhood. So we will be able to have collaborations, and we already do with Beginnings, have several very important collaborations with industry to help accelerate the development of new treatments for these babies. So this leads us really into thinking about the consortium, right? In some respects, you call it a perfect storm, is accelerating access to precision medicine. There are more and more effective and approved gene therapies. There are groups like NLORMS that is here in San Diego, that is specifically a foundation, a not-for-profit foundation that is working with clinicians to identify children with underlying genetic disorders and providing the development of antisense oligonucleotides. We begin to think about how we can shorten the diagnostic journey, and we believe that intervening to change the course of life from birth, so for those first early weeks of life, to be able to identify an underlying genetic disorder can be potentially very beneficial at providing early intervention, and that early intervention then could lead to improved outcomes. The consortium, as I mentioned, is working together with different groups, and we are really in the midst of that as we speak about that now. And then we will have stage development and clear milestones along with it. We are at stage 2 at this time, where we will, in the next few months, begin to apply the tests that we have for genomic screening to a population of babies within our newborn intensive care unit here at Rady's. And then in parallel with that, we are also working with other sites in San Diego and then really across the US, and I'll talk about some international efforts as well, to be able to identify more sites where we can move forward in being able to bring and refine and increase the scale to more sites, as you can see in this schema here. So after the diagnosis is made with newborn screening, I think some of the, at least to me, the most compelling, rather than hearing it from me, is to hopefully this will work so that I can, if you'll give me just a minute here, bear with me, I'd like to show you a video. Okay, great.
He was an absolutely gorgeous baby, and we were so incredibly happy to finally hold him in our arms. He was diagnosed with one of the rarest immune deficiencies, known as Artemis Skid. It meant he had no immune system, and we were told that he would not live to be a year old. Having a precise diagnosis allowed Fitz to qualify for a gene therapy clinical trial that could increase his chances for a normal life. During the entire process, he was always cheerful, and sometimes I would have to shake my head in disbelief of how amazing he was in light of everything that he was going through. He always had a sweet and happy temperament, loved to smile and flirt with his nurses. For Halloween, we went all out and dressed him in 5 different costumes.
7 years. 7 years.
Fitz is the happiest toddler, always smiling and always laughing. It's as if he knows every day of his life is a gift. He's not only surviving, but thriving. We'll forever be grateful that he's benefiting from two of science's latest innovations, rapid whole genome sequencing and gene therapy. And now, he's got his whole life ahead of him.
So we've begun to work with a panel of pediatric clinical geneticists. We have always from the beginning of the Institute worked with pediatric clinical geneticists, but we formed this additional panel and had more pediatric clinical geneticists come and work with us to begin to curate the world evidence about specific underlying monogenic disorders, and specifically to think about those that had effective treatments. And so we started to bring together this ability to do a systematic review of the literature, to bring together other publicly available databases, then to create a Delphi panel of these pediatric clinical geneticists so that we would be able to see whether or not they agreed on the outcome and the information and the recommendations that were being given regarding the treatment of different underlying genetic disorders. So you can see here that there are about 5,000 publications that have been reviewed by this panel so far. And this group has been really helpful and important for us when we begin to think about newborn screening using whole genome sequencing, which is why I'm introducing them. Because it really provides an easy interface for frontline clinicians, but it also provides an interface for our thoughts about which conditions should be screened for when we begin newborn genomic sequencing. And so we have that for the newborn genomic sequencing, I'm sorry to go back here for a minute, but just to let you know that we have identified about 388 conditions that have effective treatment that are related to individual variants or monogenic disorders. And we are going to begin to work with multiple international groups. So there, and I'm just wanting to make sure that I can tell you a little bit about a couple of cases. I'm watching my time here, and I have about 8 minutes left. But these are cases where we felt that a diagnosis could have been provided sooner than if the baby had been presented while they were ill. So in other words, if they had had a screen as a newborn when they were still asymptomatic, that we've, as Fitz was, that the treatment could have been more effective, or the intervention more effective, than if the use of whole genome sequencing had waited, as it does for many of the babies that we have treated in the past, when they are already in the intensive care setting. So this table in particular is our summary of about 4 cases where we saw the age at diagnosis. As you can see here, they are different diseases. One is related to blood clotting, one is related to epilepsy and encephalopathy. 1, 2, case 3 and case 4 are related to inborn errors of metabolism. And you can see that the range of years goes from 42 days to 21.5 years. I will say that it's not infrequent that we will have our internists or geneticists who are treating adults tell us about a particular case or patient where they have done whole genome sequencing and found that there was an underlying molecular diagnosis, so that the individual was really on a very, very prolonged genetic odyssey. You also see on this table how the initial presentation of clinical signs and symptoms that came, and then the age of diagnosis. We think that these cases, had there been newborn screening using whole genome sequencing available, that the diagnosis could have been much earlier, and that targeted therapy could have either prevented the disease manifestation or reduced them. Now, again, we have not done a prospective study yet. We are just beginning to, as I say, the study's designed, it's at the IRB, and we are waiting and hoping that we will begin it in the next few months. We did, as I mentioned, used the infrastructure of the genome to treatment and the expertise of the clinical geneticists to identify the first 388 conditions for which we wanted to screen. And we based this on criteria that were initially introduced into the literature in the late 1960s by Wilson and Younger, J-U-N-G as in George, E-R. And they had criteria for which they said a screening program should be deployed, but they also indicated that until these criteria were met, there was thoughts that one would not move forward with screening. So the most common one is one does not want to move forward with screening for a disease unless there's an effective treatment. And so you can see listed in the box to your right where we talk about newborn screening and what the panel considered when they were identifying those conditions for which we would initially begin screening. And again, this is in a research test environment. And this is more of the same, where on the top left, though, you can see that there are multiple publicly available databases that when we were moving forward with our genome to treatment, we brought together that information in addition to the published literature and in addition to the experts. And so this is what we call genome to treatment, and it is available, publicly available from the web. I would like to make one last comment before the acknowledgements, and that is that we are now working with Genome England. We are working, and Genome England has an initiative whereby babies will have newborn screening based on whole genome sequencing. The initiative within England is being paid for by their National Health Service. They have a single payer system as well as a secondary system, but they do have a single payer system. And so we are working with Genome England. We're also working with a group from Greece, and they are also beginning an initiative where they are going to be recruiting women during the prenatal period to ensure that they have the parents well informed to have informed consent, and then do the newborn screening when the baby is born. Our hope as we work with different groups in the States, for example, we'll be working with a group from the University of Tennessee and from the University of Wisconsin, that as we build these additional clinical sites, that we will have a common hypothesis, a very similar study design, and the same primary and secondary endpoints. And so we have had multiple initiatives or multiple meetings with these groups and the leaders from each of these groups to be able to have these studies. And now just to end, of course, this is always a team work, and many have been working with us to get us to the point where we are now with beginnings. And thank you very much again for having us present today. We will have a conference from April 19th to 20th, 2023, where one of the major focuses of the conferences will be on newborn genomic sequencing. Thank you.
Thank you. I think I speak for everybody when I say I'd love to hang out with Fitz for a couple hours.
He's so cute.
Cool.
He really is. He's a great little boy.
But we have a couple of fellows who have some questions for you. So why don't we start with Hawken Miller?
Hi, Dr. Hobbs. Thanks so much for your time today. I wanted to know, well, just some background on myself. I actually have Duchenne muscular dystrophy, so I kind of am aware of the whole newborn screening and the importance of catching things early. So, for example, with a diagnosis that is so rare, a doctor has never seen it before. How is someone to then respond to that? And, if there isn't any knowledge, or if there is knowledge, try to find that knowledge and effectively try to, treat that patient as best as they can.
Yeah, that's an excellent question. Thank you. And thank you for telling us of your own rare disorder, because I think it is from the patients that we learn the most. I will say that one of the intentions for the genome to treatment, the GTRX program for us, was to bring was our knowledge that when we spoke even to our clinical geneticists, right, they would say, this is so rare. Maybe and the clinical geneticists would say they had never seen a case like this. The more frontline physicians like neonatologists or other subspecialists would often say the same thing. I read about it, but I read about it in medical school, maybe read about it one more time or whatever, but never saw a case like this. So one of our So one of the intents was to bring together this genome to treatment to provide a public access resource for individuals, to healthcare providers, to be able to look at least the published literature in a common place to make it a little bit less challenging. I think that I'm really hopeful that one of the things with COVID, at least at our institution, is that we have much more telehealth available to us. There are the exchange of information between multiple groups, I think, will be important. We're now working with eight Children's Hospital in a program that was started at Harvard and Children's Hospital of Philadelphia and Cincinnati called Genomic Information Commons, with the intention of the more we can share information across sites, the more that we will be able to identify what is effective treatment and what is not. I think that patient registries, where parents and patients are their own advocates, is another piece of the puzzle. But I think, again, with rare disorders, it's multiple initiatives and multiple streams of data coming together to be able to provide the richest knowledge base that we can to be able to provide effective treatment. I hope that addresses some of your questions. Okay.
We now have Tan Xiao Chin from Malaysia.
Apologies for that. Okay, so as you heard, I'm from Malaysia, which is a category which goes under one of the low middle income countries. And putting aside the question of cost, which is of course an issue, I was wondering, I would like to ask you in terms of laboratory equipment as well as technicians, do we need, for whole genome sequencing, do you really need very specialized and potentially expensive lab equipment? And do you need very specialized training in order to be able to interpret the results? Meaning, I mean, is it within the reach of at least a medium income country?
That's an excellent question. I would say that within the United States, there are few sites that are able to do rapid whole genome sequencing for screening a whole genome. There are some academic sites, there are some institutes like ourselves, and there's industry. And yet, especially for rapid whole genome sequencing, when you have a baby who's critically ill, that most hospitals in the US, for example, and I'm using it as kind of a foil to address your question in Malaysia, but most hospitals in the United States do not have the equipment to do whole genome sequencing at scale, nor do they have the those individuals who are trained, either genetic counselors or genomic analysts, who are trained to be able to provide clinical data back to patients. Now, I will say that I have seen that change and become better. And of course, our hope is that we continue on this trajectory of making these tests and this technology more and more accessible, that we democratize these technologies, and that we really pay special attention to the very question that you asked. And without a plan in place to be able to do that, we won't get there. So I really applaud you for that question, and I know that we here are working to provide. We have, for example, different applications into NIH. One's specifically to be able to provide rapid whole genome sequencing to individuals in the Northern Mariana Islands, which is a territory within the US that is that you may know of, that where their resources are substantially limited. Right now we have patients who sometimes are transferred to us from the Northern Mariana Islands, and sometimes we are hopeful that we can work with them in the future so that the sample can be sent to us rather than having to transfer the baby before a rapid whole genome sequence, because we want the parents to be, as much as to keep the baby in the community as long as possible.
James Sando's microphone is not working, so unfortunately, I will ask this question for him then, and that is, will the consortium in testing 1,000 babies with WGS, will WGS involve just the babies, or will it be trio testing?
Oh, excellent question again. We will start with just the babies, and then for those babies where we have a positive or a pathogenic or likely pathogenic variant, then we will have samples from mom and dad to be able to look at phasing.
And he adds, by the way, that the Brits would not consider baby Fitz as patient 007, but rather secret agent 007. Some of the mysteries of the genetic code under his belt. Let's see, is there another question here? Is Shiraz. He's asking, are there any apps which can help rare disease babies and families?
Well, I love that question, one, because we are in the midst of working with our colleagues at Scripps Research here in San Diego to be able to, there is an app for moms who are pregnant. It's called Power Mom, and we are hoping to bring that app into the, or to bring beginnings into the context of that app, if you will, so that there will be, as we begin our research study with beginnings, that moms will have the opportunity during the prenatal period to sign on, provide electronic signature consent if they so choose to participate in beginnings, and then follow up for these babies from their time of delivery until they're 12 months of age. And that will be done, we hope, through an app. And our thinking around that is that the app and the opportunity to really buy into the digital transformation of clinical trials will be so much more user-friendly, we think, for participants, especially, you know, parents of young kids have so much to do with just everything. And if we can make it a little bit easier for them to participate in such research studies that we hope eventually will lead to having whole genome sequencing available to all, that if we can be confident or sensitive to their needs, that we'll have better participation.
There's another question. How often are there errors in the tests?
So the newborn genomic sequencing and will be the goals. We will measure that sequencing. We will measure the sensitivity and specificity of that technology, where we're looking at the 388 conditions compared to what we use now as our gold, if you will. And it's a lots of caveats around the term gold standard, but our reference standard for sensitivity and specificity when we do rapid whole genome sequencing. We have to continuously validate and improve our sequencing. It's not without errors, but I would say the number of times where we really see a misdiagnosis is quite, I would say, since I've been here, and we've done probably 2,000-3,000 rapid whole genome sequences, it's maybe 2 or 3. And that, fortunately, those errors have been brought to our attention. So we also, if we are concerned, we'll do orthogonal testing and sometimes send the sample out to another completely independent lab. Again, that doesn't happen often, but that is a strategy that we can use if we're concerned about the accuracy of our own testing.
We have time for one more question, and it comes from Diana, who was able to actually type her question in, and it actually mirrors a question that I had. We had a speaker earlier from the H3 Africa initiative to talk about what they're doing in terms of rare disease research. Diana asked, in terms of Africa, specifically underdeveloped countries where there is little or no resources for newborn screening, what are some opportunities, or have there been any initiatives or outreach from Rady or others to work with countries in Africa?
At this point, we have, I'm not aware of any. I will say, though, that we are very keen to be able to provide these advanced technologies globally, that we are working with some under-resourced countries, and that we would be more than glad to have conversations with individuals who really wanted to bring some of these technologies to Africa.
And on that note, when I think about this topic and I think about the potential of being able to detect and treat rare conditions earlier, it gives me a great deal of hope about the future of child health, about well-being and quality of life for many of these children. So this has been incredibly informative, and we greatly appreciate you joining us to inform the journalists about this research. And we hope that we can reach out to you in the future as we work on these stories.
Absolutely, Rachel. We would be delighted. And once again, thank you so much for giving us the opportunity and for the interest of the National Press Foundation in this area. And just really appreciate it.
Great. Thank you so much.
Take care. Bye-bye.
Bye-bye.